Hi, this is Allison Buttenheim. This is Module 1 of Experimental Study Designs, the Overview section. I want to acknowledge for this module and all the modules several slides that I've adapted with permission from Vic Schoenbach at the UNC School of Public Health. I'm very grateful for his sharing his terrific teaching materials. Two quick learning objectives for this overview module. We want to understand what an experimental study design is and learn different types of experimental studies. And there's lots more information, as always, in Gordis if you want the gory details. So what makes an experimental study experimental? We've definitely talked about this before. The important component here is that the investigator is assigning the exposure to the participants, actually manipulating the exposure with a randomized component. And then, as in other studies, looking to see what are the effects of that exposure on the outcome. But obviously the contrast here is with observational studies where we're not manipulating the exposure. There are lots and lots of different kinds of trials. One very common kind is a therapeutic trial, where we're looking to see if a new drug or a new device or a new treatment does better than either a placebo, no treatment, or an existing treatment on our outcome of interest. And here's an example from the BHAT study, which looked at a beta blocker. This study was published in JAMA. It's a high-quality study and a successful trial. You can see in the graph that the drug in the dark line had a lower cumulative mortality than the placebo in the dotted line. And that tends to be what the outcome for an experimental trial looks like. There are also prevention trials where we're looking to see, again, if a drug or intervention, could be a health behavior intervention or a health promotion intervention, actually helps prevent the development of disease. Here's a New England Journal study looking at maternal to child transmission or vertical transmission of HIV. This was a very successful trial. Again, it came out in 1994 with zidovudine having, again, a lower probability of transmission of the virus to the infant than the placebo. And you can see the error bars there on the right. It's a significant and substantive result. By the end of the trial, of the 72-week trial, zidovudine had actually reduced the probability of transmission from around 25% to below 10%. We can also think about intervention studies categorized by the level of randomization. So in clinical trials, we're usually randomizing at the level of the individual. So whether it's a drug or some other kind of intervention, we are randomizing, choosing at the individual level who gets the treatment, who gets the control. And the Mr. Fit risk factor study discussed in Gordis is a great example of that. We also do a lot of community trials where the level of randomization is larger social unit or spatial unit. It could be a school, it could be work sites, villages, communities. And we do that in part because it's often impractical to deliver an intervention at an individual level. If you think about a teaching intervention, it's hard to deliver that to some students in a classroom and not others, so the classroom becomes a more practical unit of intervention. We have to be careful here with community trials in our statistical power and our efficiency, and that's because people within spatial and social units, like classrooms or villages, tend to be more alike each other and more different from people in other units. And that means that those observations aren't statistically independent. We're not going to get into that level of power calculation and clustering analysis, but keep in mind that we do lose some efficiency with community trials relative to clinical. So what's a schematic for a typical randomized control trial? Here's a very simple one. We do randomization up front. This is usually after some steps to ascertain eligibility. But once the randomization occurs, one group is getting our active treatment, one group is getting either no treatment or a placebo or usual care, and we follow that group to an endpoint and ascertain differences in effects or outcomes. We also have crossover designs where the two different groups actually receive both treatments. They just receive it at two different times. So you see here in the schematic that after randomization, one group gets treatment 1, one group gets treatment 2. They then stop and have what's called a washout period, and then group 1 gets the second treatment and group 2 gets the first treatment. That's again a very efficient study design because individuals can act as their own controls. It also helps us establish any important temporal ordering. So does treatment 2 work as effectively coming after treatment 1? Does treatment 1 work just as effectively coming after treatment 2? Crossovers can be an excellent study design when planned that way, but we also have to pay attention to unplanned crossovers. And this is less common in a well-run clinical trial, small scale, run by a lab or a medical unit. But in the community, we have to think really carefully about whether some of the people in our control group ended up receiving the treatment, either by choice or by accident, and likewise whether some people assigned to treatment actually ended up either not complying with the intervention or not receiving it for some reason. And as you can imagine, if you play with a 2x2 table and see who did or didn't get the intervention based on our assignment, you can see it will weaken or attenuate or obscure a true effect of the intervention. So we need to both try to prevent any unplanned crossovers, but then also take them into account when we do our analysis. And we'll talk about that in a later module when we look at intent to treat analysis. Another really efficient way to do studies is what's called factorial designs, where we can actually look at multiple treatments in one study group just by dividing up the group into, again, different cells that might receive one or both or neither treatment. So if you see in the top 2x2 table, this group here is getting both treatments. This group's getting just treatment 2, this group's getting just treatment 1, and this group's getting neither treatment. And we can use pretty straightforward mathematical analysis to actually isolate the independent effects of those treatments on the responders. It's a much more efficient design than running 2 separate trials to look at treatment 1 and treatment 2. A great example of this is the Women's Health Initiative, which we've talked about. It actually had a 2x2x2 factorial design, so there were 8 distinct treatment groups, but they were looking at hormone replacement therapy and dietary modification and calcium and vitamin D supplementation. And you can see, again, here what you're buying in terms of efficiency. You can look at different primary outcomes across the 3 groups, different secondary outcomes, which may have been primary outcomes for other treatments that we're interested in, and any possible adverse effects. Finally, one kind of design that I just want to mention, just so you've heard the phrase, is adaptive designs. And in adaptive designs, rather than randomizing treatment and control up front and sticking with that assignment all the way through to the trial, we actually can change assignment to treatment or control as the trial unfolds. And we can do it based on which treatment appears to be doing better. One term for this is randomized play the winner or back the winner. So if you run a trial for a couple of months and clearly one drug is doing better than another, you can actually assign more people to the drug that's performing better. It's a way to more quickly get an answer, and it's a way to make sure that more respondents in your trial are taking advantage of the clearly stronger treatment. And there's actually an interesting study looking at, again, mother-to-child transmission of HIV that compared what would have happened if it had been an adaptive design versus the trial that was actually run with AZT and the placebo. And there was actually a statistically significant fewer number of infants who would have had the virus transmitted to them by their mom had there been an adaptive design. So there's a lot of excitement and buzz around adaptive designs. There is some complicated math, and you have to be careful what you're randomizing and why. But again, it's a nice way to buy some efficiency and also some speed. That's the end of Module 1, and we'll see you in Module 2.